could you also talk, could one of you please talk us through the potential impact of inaccurate coding and documentation?
Well, there's a downstream effect. It's a real domino effect. As we talked about it being a prospective system, if you start off missing a lot of codes, in 1 year, that's going to carry over to the next year. And the next year, the slate is wiped clean and you have to start all over. But you're already kind of starting off at a loss. And so it's a bit of a slippery slope. And it really does take a lot of effort to get ahead of that cycle, to try and improve the documentation in a manageable way, the strategies that Bill's employing, very specific provider education, looking at the data, working with the incentive programs for providers, et cetera, really trying to audit charts and look for examples where they could be recaptured or where that could be turned into a very specific educational opportunity. It takes a lot of effort, but once you make that improvement, the other populations that are served by that provider audience will benefit too, and it'll also improve the underlying benchmarks for other risk populations within the organization. So it takes a lot of effort to start the program, but there's a significant downstream effect, either upside or downside, depending on how well you address that. There's a lot of opportunities.
So SCIO is addressing or is analyzing the claims of 10,000 patients of ours. But as I may have said before, we have 120,000 patients who are in one way or another impacted by HCC coding. So what we're learning from SCIO can be translated to these other populations. And just as importantly, the education we're giving providers will be for those providers to use across all different payers. But inaccurate or inappropriate documentation, if the code is billed for and there's not accurate documentation for it, then you're really at risk for an audit from CMS, which would not be pleasant. We are not heading towards that in many different areas, but there's a major insurer that's being sued by CMS because they're being accused of pushing providers to excessively code. Let's just say that.
Mm-hmm. So a good example on the compliance side of how that can put an organization at significant risk. And on the flip side of that, we started out talking earlier, and if you look at what our survey respondents said, most of them are in a position where they have multiple risk structures in place, and they are actively taking on more risk.
Right.
And we know that the market is moving to where that risk is moving more and more to having to take on downside risk or being forced into taking on downside risk, especially all our ACOs or MSSPs that are going to be forced to make a decision to move off track one, either take downside risk or exit the program. So the trends are showing us that you can't win by ignoring this problem. You could be in a compliance issue, in fact, and also the benefit to taking on more risk is, in order to take on more risk, as the industry is moving, you have to have accurate documentation. You have to improve the documentation to reflect accurately what that population really looks like and what conditions they have.
The one thing I'm really impressed by is the lack of knowledge of the providers that these need to be coded annually. HCC codes need to be coded annually every January. Once you get into that process and you start coding them, the following year is easy. But the first time you do it, it's going to take some time. And so we have it being performed at our annual wellness visit, and we're trying to narrow it down to 4 or 5 HCC codes that should be captured. But the providers keep giving us feedback that we don't think you need to capture an amputation every year. We don't think you need to capture depression or alcohol dependence or these things that are lifelong conditions.
It's in the EHR, right?
They
see it in the EHR. It's right in front of their face.
Why should I document it? I document it. It's going to come back. Well, CMS thinks that it goes away and you have to redocument it.
Right.
It's a game to some extent, but it's an important game to understand.
To stay ahead of the game.
Exactly.
Mm-hmm.
Oh, thank you so much, Bill and Donna. Great discussion there as well, and some of the things that providers really need to pay attention to. So what I'd like to do now is I have one more question that either one of you can answer, and then I'm going to transition us over to the audience Q&A, where the audience can ask questions of our two speakers. So Bill or Donna, if you both want to reply, we've talked a lot about coding and documentation tied to revenue, but can you talk about the impact on quality?
Sure. Is everyone seeing the slide that's up there showing accurate documentation, right?
Mm-hmm.
I want to just go over it very briefly because the first part of it is how NEMG is currently documenting. If a patient has diabetes,
You can look at it.
Okay. If a patient has diabetes, and all you say about the patient is that the patient is 68-year-old male, whatever, something like that, you get the 0.319 of the RF, which is just the demographic picture. If the patient is accurately coded, let's say with some education, you say that the patient has diabetes with complications, has vascular disease, and heart failure, all of which are HDC codes, and all of which have fairly significant RFs, which you add to the demographic RF, and you have an RAF of 2.186 in this situation. If you've had a contract, if the insurer has a contract with CMS to receive a certain amount of money per RF, in the first case, you would multiply that, and I think it's about $600 per month. You multiply that by 0.319, and that would give you $2,550 for that insurer to take care of the patient every month. The second scenario is where we've done a better coding. You multiply now a 2.186 times 600, and you get $6,000 per month. I think it's per month. And then if you go all the way and you really do a good coding and good documentation, you get diabetes with complications, vascular disease, with atherosclerosis of the lower extremities with ulcers. That's one of the higher RF factors, and chronic CHF. You add all those up, and it comes out to 2.485. And now the same patient with better documentation is now getting from the insurer, gets from CMS $19,000 to care for that same patient. Clearly, you're going to have a lot more profit taking care of the patient with $19,000 per month than $2,550. The quality part comes in is we now know this patient has a 2.45 risk factor. At NEMG, we are now stratifying patients by risk factor. And, for example, if they're in as an inpatient, we're going to make sure they don't get readmitted by having close care coordination. We're going to make sure they come in for their annual wellness visits and all their quality measures. That will not only result in more money, as I said, to the insurer to take care of the patient, but if you take care of the patient based on these quality measures and keep the patient from coming in the hospital, you're going to spend less money taking care of that patient than you would have. So the two benefits are the insurer gets more money to take care of the patient, it costs less to take care of that patient, and as a provider in a risk-sharing contract, we would make a fairly good profit out of that same situation.
And even to build on that example, vascular disease, lower leg ulcers, they're, referring the patient for diabetic foot care and for the appropriate referrals that they need, making sure they get their lab values, their A1Cs and their cholesterol, et cetera, every 6 months. Our quality gaps, their quality measures that are going to get reported.
Yep.
And the program will work better for the patient who is those services that they badly need are identified up front and coordinated through the organization. So the patient receives better care and hopefully can get into more of a preventive mode and less of a reactive mode or end up in the hospital or the emergency department.
In fact, there's a new study out by Optum. It was for a large California health system that's been doing this for 4 years. And their RF for their patient population was about 0.9. It went to 1.2. It went to 1.3. and then it went down to 1.2 to 1.0 because you were preventing the diabetics from getting complications, the diabetic with lower vascular problems from getting ulcers, the COPDs from becoming chronic respiratory patients. So even though a lot of people talk about this as far as the revenue potential, I think that if you use this information for quality purpose, you're going to get a double benefit for it.
Absolutely. Thank you so much, Donna and Bill. Your explanation of this particular slide just makes such a good case of why it's important for accurate and comprehensive HCC coding. So we appreciate that explanation.